morning, everybody. Welcome to our HDSA New Jersey Chapter Education Day in conjunction with Cooper Hospital. So I really appreciate everybody being here. To start off, I just wanted to let everybody know that this event is funded by the Huntington's Disease Society of America in conjunction with Genentech and Unicure. So we really appreciate all the support that they give us. Today we're going to be, I'm going to be briefly discussing some advocacy issues. Then we're going to hear from Dr. Amy Colcher, who is the director of our Movement Disorder Center at Cooper. We're also going to be hearing from Dr. Andrew McGarry, who's an attending neurologist at Cooper Hospital in our Movement Disorder Center as well. And then we'll be hearing from Kayla Cupano, who is an occupational therapy doctoral student, and she's going to be talking about some issues with us there. So I really appreciate everybody being here today. Again, I'm going to briefly touch on some advocacy issues. So the first one that I'm going to talk about, and I'm going to share my screen, so bear with me for a minute here. All right. Okay, so the first thing we're going to talk about that's just really important for everybody to be aware of is that we're still fighting for the HD Parity Act. Which would give individuals with HD access to Medicare benefits without a waiting period. So currently there's a 2-year waiting period for Medicare once you are determined to be disabled. And there's 2 exceptions for that right now, which is if you have ALS or if you have end-stage renal disease. And so it's really important that we've really been working hard to get HD added to that. So one of the ways that you can help with that is by contacting your congresspeople. And so what we find most effective is, especially if you're able to tell your personal story about how this has affected you. So that's one piece of it. You can go to hdsa.org/takeaction and send your member of Congress a message. So we make it pretty easy for you. But certainly feel free to reach out on your own. And then my understanding too is that they respond well to social media. So you want to make sure that, you know, if you see a Twitter account or an Instagram account that belongs to your congressperson, you know, feel free to reach out to them that way as well. That's another effective way to do that. So that's our first piece. And then the second thing that's happening coming up in New Jersey, I'm going to share this flyer. So if you're a caregiver in New Jersey, there are some Zoom meetings coming up in March where they want to hear from you. And so they're going to be doing these sessions. You can see them on the side here. Saturday, March 6th from 10 to 1, Wednesday, March 10th from noon to 3, and again, Thursday, March 18th from 5 to 8. They will be Zoom meetings, so you don't have to leave your house, but they want to hear from caregivers about what the issues are. So if you decide that you would like to attend one of those, Ned Cansemo, who is on our board, has asked that you could email him at ncancellmo@gmail.com. And so if you could reach out to him, that would be great so that he has an idea of when folks might be joining. And so that's it for advocacy. Certainly if anybody has any questions, feel free to let me know. During this presentation, we would ask that you stay muted unless you have a question, but we'll be asking questions more toward the end of each presentation. And then also you're more than welcome to use the chat box at the bottom. So if you have any questions, I should be able to see those as people are talking. So I'm going to introduce Dr. Amy Colcher, who's going to be talking with us today. And so I appreciate your time, Dr. Colcher. And I think I'm supposed to put a pin on you. So let me give you one of those. Ah, there you go. All right, excellent. And I think you're on mute, so you may need to, there you go. Ooh, for some reason, I'm still not hearing you.
Hear me now?
Oh, I can. There you go.
My technology is terrible. All right, I'm gonna try and share my screen with you.
We've all gotten so much better with this, right? One good thing.
Gotten better, but still a bit of a struggle.
Let me share my screen.
Oh, I need to allow that. Let me see. Ah, there we go.
Yeah.
Okay. Does that help?
Yes.
Okay. Perfect.
Okay, make this bigger. Okay. Okay. So I thought that today, since we're in the middle of a pandemic, we would talk about COVID-19 because I think there are probably more questions about it than there are actual answers. But I thought we go over the neurologic complications of COVID-19 because I think that is a big question in everybody's mind, especially now the vaccines are rolling out and who gets on the list as the first group of people to be able to get the vaccine, and why is it that certain people are placed ahead of other people in terms of the timeline for getting vaccinated, who's more at risk, and what actually are the problems that result, or at least neurologic problems that result of the COVID-19 infection. So I think I get questions from patients, I get questions from my friends as if I'm a doctor and I should know everything. So I thought I would put this into a neat package and hopefully enlighten all of us about what can go wrong as a consequence of COVID-19. So just to start out, the pandemic that we're in started as an outbreak in China in December of 2019. And essentially, it's a respiratory syndrome. It's a severe acute respiratory syndrome, shortness of breath, difficulty breathing, sometimes necessitating ventilatory support. It quickly spread to involve the entire world pretty much. So multiple countries being affected, rapid progression of spread, which is then what classified it as a pandemic. The most common symptoms are respiratory. So it is a pneumonia. It causes acute respiratory distress syndrome. People lose their ability to oxygenate their blood, so they're short of breath, or they don't feel short of breath, but their actual blood oxygen levels are very, very low, which is not compatible with thinking clearly and functioning well. People can be affected mildly, or they can be affected more severely. So the mild symptoms are fever, fatigue, and cough. The more severe symptoms, obviously, respiratory distress, and then it can cause kidney failure, heart failure, and obviously death. These are statistics that I pulled in the last week, just looking at the overall numbers in the United States. So far, we've had 490,000 deaths and 27.9 million cases. Worldwide, it's is that right? Yes. 2.4 million deaths and 110 million cases. So this is a huge worldwide problem that we're all dealing with, and it's nothing that any of us have lived through before. I think there are probably very few, if any, people that survived the last pandemic we had, which was the Spanish flu in like 1914. So I doubt that anybody is alive that survived that. There may be people that had family members that did survive that. So they have a sense of what the sequela of that kind of a pandemic was, or what it was like to live through a pandemic like that. But in our collective human experience, there hasn't been anything like this that we have any point of reference for. So that's what makes it even worse for all of us trying to deal with it. the neurologic issues in terms of COVID-19 is primarily respiratory. So the fear has been respiratory failure, the need for ventilatory support, and that's where our hospital system has gotten overwhelmed, not having the appropriate um, machines or the number of machines needed to take care of all the people that needed them, especially when the numbers started rising so acutely and so fast. But there's two different ways that the virus can get into the central nervous system. One is through the nose. There's a very small sort of bony plate at the top of your nose, between your nose and your brain, and the virus, if it's inhaled, can go through that cribriform plate and gain access to the brain. Or it can get into your bloodstream and then get into the central nervous system that way. We still don't know. When I looked at the literature in terms of trying to get ready for this talk, it's not clear if the neurologic problems are really the result of the virus getting directly into the brain or the central nervous system, or they're the result of the other organs that are damaged, and then the toxins from those other organs not working, building up and causing neurologic issues. So definitely people that are sicker are much more likely to have neurologic issues from the virus. And we worry about all the complications of the virus from the multi-organ failure as well as the primary neurologic issues. So what kind of neurologic issues are we talking about? The first one I want to just touch on is the anosmia, the lack of the sense of smell, which is very, very common as one of the initial things that people notice when they are infected with COVID-19. And so I'll admit that in my house every morning we wake up and check if we can smell things. And I guess lucky or not, I don't know if I should share this here, but I have an old dog who doesn't always make it to the backyard when he has to poop. So that has been my way of checking that I did not have COVID, is as long as I can smell when he's had an accident, I think everything is good. So that's my way of turning negatives into positives, which is important for all of us to do in the midst of a pandemic. But that lack of sense of smell is very common, happens to the majority of people early in the course of the disease. So I think it's a pretty good indicator that somehow the virus is getting into your central nervous system and at least affecting your olfactory system so that it impairs your sense of smell and then impairs your sense of taste. And headache is also one of the early symptoms of COVID-19. So lots of people complain of headaches, diffuse body aches, dizziness. Confusion can happen sort of at any course along the timeline of the infection. It can happen in the beginning. It can happen after you've recovered from the infection. There's a lot of literature about brain fog related to COVID-19, so that people, even though they have recovered from the respiratory part of the illness and the other issues in the illness, still are feeling like their thinking is not clear and they're just not as sharp as they were. And that can persist for variable periods of time. So we are ending up seeing a lot of people with sort of, after recovery from the illness, a lot of complaints, more non-specific complaints of fogginess, tiredness, lack of motivation, mood issues that it's hard to piece together exactly what part of the nervous system was damaged to cause these symptoms, or how they are related to the infection itself, as opposed to just the whole situation of being infected and living in a pandemic. Stroke was the first major neurologic complication that was noticed in terms of hospitalized patients with COVID-19, and seizures are much less common, but we're going to go into all of those in a little bit more detail as we go on. But definitely there's a variety of ways that this virus affects the central nervous system, and a lot of issues that people who are infected have to deal with neurologically. And especially, I think you want to keep this in mind in terms of Huntington's as well, which is already potentially causing problems with thinking, problems with mood, problems with levels of consciousness, problems with balance, problems with energy and motivation. So all of those things, it's hard to tease out what's the virus and what's the disease. So it is going to be challenging for all of us, I think, as time goes on. The other thing to keep in mind, and this is not specific to COVID-19, is that when you have a neurologic illness or you have any kind of illness, but something like Huntington's disease, your body is doing everything it can to compensate for the problems associated with HD. So it is working overtime, trying to keep your balance good, trying to keep your speech good, trying to keep your swallowing good. And all of those things are going on without your consciously knowing that that's what's happening. But then if you get sick with something else, if there's some other stressor on your body, whether it's a physical stressor, like you fell and broke your hip, whether it's a infectious stressor like a virus like COVID-19, or it's an emotional stressor like you lost your job, or your kids went off to college and moved away. Any of those additional stressors are going to sort of end up at the front of the line in terms of what your body needs to process and what your body needs to take care of. So the Huntington's is going to take a back burner while these new stressors are being addressed by your body, which means that your Huntington's symptoms may worsen. If you have extra movements, they may get worse. If you're not thinking clearly, that may get worse. If you have a tendency to be depressed or have more obsessive compulsive thoughts, those things may increase when you're trying to deal with the new stressor. So that is typical no matter what the stressor is. But in a pandemic where that stressor, it doesn't just go away quickly. Like if you break your hip, you have surgery or you go to rehab and things get better in a period of weeks or maybe a couple of months. This has gone on for a year and we don't have any sense of when it's going to be over. So that is going to wreak havoc with the other conditions that people have and that have been trying to compensate for. So that is all normal in terms of having a chronic disease and having additional stressors on it. I think that what is unique about this is that it is a pandemic and that we don't have enough information about when it will be over or when things will start to get better. So there is so much uncertainty around this that is going to make things much worse for all of us with or without Huntington's disease. Okay, so let's talk about stroke for a second, because this is the first issue that was really um, brought to the attention of doctors who were treating patients in the hospital. And what they were seeing was big strokes in people, even young people who had been infected with COVID. What happens is that the virus gets into the lungs and it causes damage to the very small parts of the lungs. That is where the blood exchanges the oxygenated blood for the blood that's already had the oxygen taken out of it. And this damage triggers an inflammatory response. So when things get damaged, inflammatory cells come in, they release chemicals that promote the inflammation, that bring white blood cells in to help and cause swelling and things like that. So those inflammatory chemicals are released, and those inflammatory chemicals can actually damage blood vessels. So in a normal blood vessel, the inside of the blood vessel is nice and smooth so that nothing sticks to it. But when those inflammatory chemicals get in there, they start to damage it and it's not so smooth. And it makes the smoothness is what makes things not stick to it, because you want your blood vessels to be smooth so the blood can easily flow through. If there's damage and it's not smooth, then things start to stick to it and the blood vessel gets narrowed, and then more things stick to it and it gets more narrowed, and eventually the blood can't get past that narrowed area and causes damage to whatever that blood vessel was supplying. Also, the things that stick to it can break off and fly up to other parts of the body where they don't belong. So that's what we worry about. We call thrombosis, where these little sort of blood clots clog up the blood vessels, and then they can break apart from smaller blood vessels and go to larger blood vessels and go up to the brain and cause blockage in the blood vessels there, and that causes a stroke. So that is how sort of the mechanism of how COVID causes strokes in people that otherwise would not be at risk for stroke. We also know that not moving around predisposes us to blood clots. Those are blood clots in the veins, not so much in the arteries. But deep vein thrombosis is a complication of being in one position for a long period of time, or not getting up and walking as much as you used to. So we definitely see that in hospitalized patients, getting deep vein thrombosis, which can then break out off of the leg veins and travel up to the lungs and cause what's called a pulmonary embolism. If the heart is not completely intact, sometimes those clots can go through the heart and up to the brain as well. So that is another cause of, or potential cause of stroke that we see in hospitalized patients with or without COVID. And that's why if you're ever in the hospital, the reason that they put those compression boots on you, those boots that sort of blow up and squeeze the bottom of your leg sort of rhythmically, is to prevent those blood clots if you can't get up and walk. So ideally, the best thing to do to prevent those blood clots forming in your legs is to move. But if for whatever reason that you're in the hospital, you're not allowed out of bed, you can't really get up and move, then they use those compression stockings, and sometimes they'll actually use blood thinners that they give you every day to try and make it so that nothing sticks to the inside of your blood vessels and causes clots that can give you problems down the road. So stroke is a major complication that was sort of an unexpected complication of what we thought initially was a respiratory disease, but ended up being a big problem for people who were hospitalized with COVID down the road. And then the sequela of stroke is that after you've had a stroke, depending on what part of your brain was damaged in the stroke, you're left with the damage from that, whether it caused vision problems, whether it caused weakness or sensory loss or incoordination. Having COVID doesn't predispose one part of your brain to getting damaged. So then you need not only to have rehab to help with your lung function and your breathing and your energy, but also to get better in terms of the damage that the stroke would have caused, whether it's language or strength or sensation or walking. So those are things that people are dealing with after they get out of the hospital as well. There is another condition called critical illness polyneuropathy or myopathy. So this happens in people who have been in the intensive care unit for a long time. And they're essentially, again, it's due to this diffuse inflammation that happens, and the chemicals damage the blood vessels that go to the nerves and the muscles, and then the nerves and the muscles don't work. So patients with critical illness polyneuropathy or critical illness myopathy are weak. They really can be so severely weak that they can't move at all. And because especially our peripheral nerves don't have a very good blood supply, when they get damaged, it takes a very, very, very long time. I'm talking months and months and months to get better. So this can be a very hard thing to treat. And ideally getting the patient better from whatever their underlying illness is and getting them out of the intensive care unit as quickly as possible should help to get them better faster. But it is a very, very slow process, and that can keep them in the hospital longer than they would have been otherwise if they didn't contract this. So it's something that we as neurologists, when we are going in to see people in the hospital, when we get consulted because they're weak, this is something that's always in the back of our minds as something that could be a problem in patients who are in the hospital for a long time and who are very sick. Seizures is another thing that we worry about. People who have been in the hospital or in the intensive care unit. Um, in people who already have seizures or people who have epilepsy, there's definitely been seen to be an increase in seizure frequency in patients with COVID-19. And there's a lot of reasons that this could be. One could be that you can't get to your doctor because it's a pandemic and you can't actually physically get to see them, or you're nervous that going to the doctor's office is going to lead to exposure to people that could be sick, so you don't go. It could have to do with not being able to get your medicine. Some people don't get to the pharmacy. The pharmacies may not stock everything that they used to have. The mail service, as you know, in the past year has been abysmal. So people that get mail order medicines their medicine may have been delayed. And seizure medicines for sure are things that you need to take every day. You need to have a steady level of that medicine in your bloodstream so that it can keep you from having seizures. And if you miss it for a week or a number of days, then that level is going to go down and it's going to predispose you to more seizures. And again, the stress, just as we talked about before, the stress, any additional stressor is going to make it harder for you to cope with the disease that you already had. So the additional stress can affect sleep, which sleep deprivation definitely leads to more seizures. And so that stress as a sort of a big all-encompassing term can make people who have had seizures have more seizures. In people who have never had seizures before, we do see an increased incidence in seizures with the virus that can be from not getting enough oxygen. So definitely from the pulmonary issues where you're not getting enough oxygen in your bloodstream, that deprives your brain of oxygen and then can cause seizures. Other metabolic problems, like if your liver isn't working or your kidney isn't working or your ammonia level is building up, all those things can predispose to seizures. Other kinds of organ failure can cause seizures. So kidney, liver, heart failure, all of those pulmonary failure, all of those things lead to buildup of products that can make you more susceptible to seizures. Definitely medications. So typically when you're in the hospital, medications are added that you hadn't been on before. Some antibiotics make it more likely for you to have seizures. Some other medicines that could interact with medicines that you're typically taking can make you have seizures. So it's really important to look at what medicines you're taking, if the medicines that they've added in the hospital make it more likely for you to have a seizure. And then brain damage, definitely having a stroke, having a part of your brain that is damaged, that part then becomes a little bit more irritable. Cells are firing when they shouldn't, and that can cause a seizure as well. So we do see in hospitalized patients with COVID-19 an increase in seizures more than would have been expected. Encephalopathy is a fancy word for saying that your brain isn't working quite right, usually characterized by symptoms of confusion, sometimes hallucinations and psychosis as well. We see it frequently in people who are in the intensive care unit. Um, and some of that is just from being in the intensive care unit. If you've ever spent any time in the hospital in an intensive care unit, the lights are on all the time. So your whole day night sense is gone. It's light, it's noisy, it's not easy to sleep in there. There's people, because you're so sick, there are people in there checking on you every hour or so to check your blood pressure, to make sure your IV is okay, so that it's hard to get a decent night's sleep. It's hard to know what time of day it is. There are not things that tell you what day of the week it is, what month it is, so your sense of time is distorted and gone. So it is very easy to get confused when you're in the intensive care unit. Other things, just like we talked about with the seizures, that can make you confused when you're in the hospital are lack of oxygen, if your kidneys aren't working, if your liver's not working, if you have a bad infection, that can make you confused, if you have a fever. And again, certain medications, as well as problems with sleeping, not having familiar faces around, not having people that you know, and especially during this pandemic when visitors are restricted to the hospital. So you end up in the hospital with COVID and nobody that you know can see you. You're sort of at the mercy of all these strangers who come in, and they're all masked up and gowned up, so you can't even really see their face. It's very confusing, and it's a very sort of novel problem that we hadn't had before, because at least sort of the human characteristics of the people that are caring for you when you're in the hospital were obvious before, but now these are masked people with eye covering and gowns on, and so it's even hard to recognize the same person who comes in from one day to the next, especially if the equipment is noisy and it's hard to hear their voice through their mask. It is a setup for a lot of confusion in patients who are hospitalized during a pandemic. Okay, now let's talk about the sort of the neuropsychiatric complications of COVID-19, which I think is huge in the Huntington's population. The confusion is very common. It's sort of being less oriented, not knowing exactly where you are, what day it is, what time of day it is, that kind of confusion. They've also seen a lot of what they call a dysexecutive syndrome, which can also be a problem just in Huntington's without COVID, but it could be made worse by the disease. So not being able to pay attention, not knowing exactly where you are, not being able to plan things out. There is definitely a rise in post-traumatic stress disorder. I mean, I think that we've been living with this pandemic for so long that we sort of forget that this is a pandemic. This is a huge, huge stressor to be living in an era where people are dying, people who are not sick are dying, young people, children, older people, family members. You can't spend time with them. You can't see them when you want to. Even just living your normal life, you can't see your family members because we're too afraid of infection. All the holidays last year were spent much more in isolation than they had ever been before. So that's traumatic for many people. And so it's not, it's not the same kind of trauma as having been in war, but it is traumatic nonetheless. And so people have nightmares, people have flashbacks to being in the hospital, being isolated, or flashbacks of imagining their family members all alone in the hospital and not being able to see them. So we need to really be cognizant of the fact that this whole pandemic has been a trauma for all of us, and that PTSD is not a diagnosis to be ashamed of, or is not something that only happens in people who've been abused or people who've been at war, but people who've lived through pandemics can get it as well. Definitely worsening mood symptoms, worsening depression and anxiety, suicidal ideation, and mood swings are all seen as complications of the pandemic. We see people getting more psychotic, having hallucinations, having delusions, believing things that are not true, and then those non-specific symptoms of just feeling tired, feeling irritable, feeling like they just don't care about anything, they have no motivation to do things. All of these seem to be sort of side effects of this pandemic, for people with neurologic issues and for people without neurologic issues. So it's very, very pervasive. It's very, very common. And just one more thing that we get to blame on COVID-19. Eating habits. This I thought was interesting. There was a study done in Italy, um, looking at over 3,000 people. They studied them from kids to older people, and 48% of them felt that they had gained weight from the pandemic. So, what happens when you have a pandemic and you have sort of forced isolation is that we all stay home. And what do we do when we stay home? Well, we may not be able to go to the grocery store to get as many fresh fruits and vegetables and healthy stuff for us to eat. So we eat the stuff that is in our cabinets, which is pasta and rice and all the comfort food that we love, but it's not so healthy. So we gain weight. We're also told that we need to stay away from other people, and we can't go to the gym anymore because the gyms are closed. So it's a lot of sedentary activity. We're not going out, we're not exercising, we're not doing as much physical activity, and we're eating to try and make ourselves feel better because we're bored, because we can't see our family, because we feel bad, and lots of people will use food as comfort, and so they will eat more. Interestingly, a small percentage of people quit smoking during COVID, which may again be access to cigarettes, not being able to go to the store as often, not being able to get out and get the stuff that you're used to getting. Um, Only about a third, a little more than a third, people actually increased their physical activity, so that when they were not able to go to the gym anymore, they found other ways to increase their activity, maybe walking around outside if they had a place that didn't have a lot of people in it. And then another small percentage of people started eating healthier, so eating more organic food, trying to beef up on the fresher food and trying to keep themselves healthy that way, because that was something proactive that they could do to try and increase their health. So there's a lot of changes in eating habits seen during COVID, and so trying to be attentive to what people are eating and looking at eating behaviors to try to keep us eating as normally and as healthily as possible is really important, especially in the wake of a pandemic. There is also something that we see called defeat stress. So, where we feel unable to cope with what's going on in front of us and to make things better, which is huge in the setting of a pandemic like this, where here's this virus, so many people are getting it, and what can we do to make things better? It seems like a very daunting question, that there may be nothing that we can do, or we may feel like there's nothing that we could do, and why should we try, because there's no hope. It is not, it can lead to demoralization, um, which is not responsive to medication. If you really feel like there's absolutely nothing you can do and there's no hope, antidepressants are not going to help you. So, what we need to find, or what we need to do when people are feeling this kind of defeat stress, is to be encouraging, to be supportive, to try and get them engaged in things that they can master, so that you feel like you have some control back. So let's say, so we're in the middle of a pandemic. I'm feeling terrible. I'm feeling like there's absolutely nothing to do. You know what? Maybe I could learn to make bread. And so which probably other people had this idea because there was no yeast for a really long time. But so you get the ingredients, you practice making bread, and eventually you make a good loaf of bread, and you feel like, look, I can do something. I can learn something. I can do something positive. I can master some skill, even though I can't get control over the pandemic. I can get control of this one little thing. And that helps to get rid of that defeat stress and avoid that sense of demoralization, where it just takes away your feeling that you have any power over anything. So this also is something for all of us to keep an eye on in the middle of a pandemic, is really trying to find stuff that we can do that makes us feel competent, in the face of something that is making us feel really powerless. Depression. We all worry about depression, especially in Huntington's disease, but definitely in the United States, they've seen higher levels of depression during COVID-19, 3 times higher in all age groups than before. Women definitely more so than men. So if you're going to say that 10% of women were depressed before COVID, during COVID, about a third of women report being depressed. Men, 6.9% before, and during 22%. Married people do have lower depression rates than people who are not married, who are widowed or divorced or separated. People who have lower incomes are more likely to be depressed than people who have higher incomes, and especially in the light of the sort of employment status, that so many people got laid off because of COVID, that not having enough money becomes a huge concern. If you didn't have a stockpiled amount of savings and you're really living from paycheck to paycheck or stimulus check to stimulus check, that is very unnerving and very depressing. So it makes sense that people who had higher income jobs, who were able to maintain their job, had less depression than people who have lower income jobs and who don't have a lot of savings. The other stressors in your life also contribute to depression. So having other stressors besides just the COVID makes it much more likely that you're going to be depressed. So definitely talking about mood, asking about mood, to family members, making sure that this is not sort of left on the back burner so that things get out of control. There are definitely medicines, therapies, online therapy has been much more available since COVID started, so that there are still people to talk to, even if you can't physically get to them. But this is not something to be ignored, because we don't want to see rises in suicidal ideation or suicidal behavior because the pandemic and in patients that could be treated despite the pandemic. And this is just looking at statistics during COVID. You can see the lighter blue color is during COVID, and the darker green color is before COVID, years before COVID. And you can see that the numbers of people with mild, moderate, moderately severe, and severe depression has increased significantly during this pandemic. So it's a huge problem, and it's something that we're gonna need to address. But it is not something to be embarrassed about, and it should be something that you talk to family members about, and talk to healthcare providers about as well, so that it can be treated, because it is treatable. Sleep is another thing. Okay, so we're used to going to work every day, and now all of a sudden we are not going to work every day. Our kids are used to going to school. They're not going to school. They're homeschooling. So our whole daily routine is changed because of COVID. So that problem of sheltering at home changes the circadian rhythms. It makes you go to bed later. It may make you sleep later, so that you're spending more time in bed. You may have trouble spending more time in bed because you feel like you can't sleep, you can't fall asleep, you can't stay asleep. Sometimes that's because of what we do at home. We may drink more caffeine, we may be more anxious, we may drink more alcohol to try and calm us down. And as we're all doing right now, we're on the computer, we're in front of the TV, we're binging on movies and TV shows that we didn't spend as much time doing before. So that all that screen time is terrible for your sleep. So you want to try and limit it as much as you can, but sometimes that's just not possible. So all of that leads to sleep disruption. You get bored in the middle of the day and you decide to take a nap. Napping too long in the middle of the day is definitely going to make it harder for you to sleep at night. Drug use, whether it's marijuana, whether it's opiates, whether it's alcohol, all of that can change your sleep patterns and make it harder for you to get a good restful night's sleep. So paying attention to, I'm going to call it sleep hygiene, trying to go to bed at the same time every night, trying to keep your room dark, trying to limit the screen time, definitely within an hour of when you want to go to bed, but trying to stick with a routine despite the fact that your whole life has been turned upside down and your routine is not what it was, is going to be very helpful, because sleep is good for your thinking, sleep is good for your mood, sleep is good for your energy. So paying attention to good sleep hygiene is huge in terms of combating the side effects of COVID-19. Okay, good. So any questions, anything I didn't touch on that you wanna, that maybe I can answer for you?
Thank you for that information. Certainly, if anybody has any questions, you can unmute yourself and ask the question, or if you'd like, you can put it in the chat box and then I can ask it for you. All right. Here, I'm gonna, let me just see. You could also raise your hand if that's helpful. Although some of you I can't see, so maybe it's not helpful. All right, excellent. All right, well, thank you, Dr. Colcher. I really appreciate that information. I know we do get a lot of questions about COVID, and it has been surprising to see some of the neurological effects that I think, you know, we thought lung disease, not neurological disease, and we're seeing some of the long-term effects are doing just that. So thank you very much.
All right, thank you guys.
So our next speaker is going to be Dr. Andrew McGarry. He's a member of our HDSA board and also, again, a movement disorder specialist at Cooper. And so, Dr. McGarry, are you there?
I am. Hi, Corlin.
Hello. All right. Are you able to share your screen with us?
I will try.
Okay. If you can't, let me know, because I think I have yours around here somewhere. So. All right.
All right. How did that go?
I think that's good.
Let's see. So you can see the first slide still in the PowerPoint format. So if I go to slideshow. All right. How's that?
That works.
Okay. Let's see. Let me just get my bearing. All right. Well, good morning, everyone. Thank you for your time. Whoop, oh, so I don't have my bearings. I'm sliding through these already. Here we go. What we were aiming to talk about today, after that really excellent talk from Amy, that was excellent practical clinical advice, was something scientifically that I don't think necessarily gets a lot of attention. And from a research standpoint, is becoming of more interest to us. So we thought we'd share it with you and see what you thought. And it pertains to the cerebellum, which is a very important part of the brain that isn't always thought of as part of Huntington's disease. So first off, what is the cerebellum? I have a picture here, just a simple schematic of the brain that is familiar to most people from, in passing on TV when you see an MRI, or if you've had imaging done, you might have been shown something like this. And the majority of the brain is this big sort of wrinkly structure that has a tube, if you'd like, kind of hanging out of the bottom. And nestled between that sort of tube-like structure and the big wrinkly part on top in the back that you see colored in false color there in orange, that's the cerebellum. And it's really quite important. It has nearly 80% of your neurons, give or take, depending on where you're reading. And so that often surprises people, because when you think about the brain, we tend to think of the cortex, which is the outer lining, certainly very important, certainly many neurons, but not even close compared to how many neurons are in the cerebellum. And that has something to do with its design, which is quite intricate. So the cerebellum's function is very intricate, and therefore there's a lot of sort of neuronal horsepower, if you'd like, required, a lot of neuronal person power, if you'd like. And so its main job, although it has some really surprising roles too, is to help with coordination and smooth voluntary movement. So if you think about moving through your day and all the things that you have to get done in an accurate and coordinated fashion, tying your shoes, pouring milk into your cereal, putting a harness on your dog before you go for a walk, it's very easy to take for granted that that information has to come from somewhere, and it also has to be compared while it's happening, while that command is being executed, to what is actually happening. So there's what you intend to do. I'm going to slip this harness over Riley's head so we can go for a walk. And I know his left paw I got to pick up to do that. I intend to do that. But then somewhere in my brain, in my nervous system, there has to be real-time decision-making about whether that is in fact happening. And your cerebellum has a lot to do with that, because it gets all sorts of interesting information about what you're seeing and what you're feeling, literally in your hands, the weight of the harness, the weight of your dog's paw, the position of your limbs, where your trunk is in space. Are you balanced when you're leaning down to do this? As you think about it, there's a lot that goes into executing voluntary movement that you intend. And so the cerebellum, because of these large tasks, really, as you think about it, is quite complicated in the sense that there's a lot of neurons in there. It's very heavily connected to the entire nervous system. So it gets information coming down from the cortex, which is where strategies and motor patterns are being sent to it, the things you intend to do. That's I intend to walk my dog part. How do I do that? Well, I got to put the harness on. How do you put the harness on? That kind of thing. And it also gets information coming from the outside. So if we think about the spinal cord and the brainstem towards the bottom of that picture, that sort of tube looking thing hanging out of the bottom, that's actually a giant highway that's also sending information upward. And so where you are in space, where your limbs are, where your hands are, what you can feel in your hands, all of that information is going to the cerebellum, who's then crunching it to be sure that in real time, what you're intending to do is actually what's happening. So as you think about it, it's really an amazing part of the brain. And so because it is fairly complicated, we have to make it uncomplicated. And this is not meant to make it complicated. So please bear with me. We won't spend a ton of time on this slide. But the idea here is that the cerebellum also has layers like the rest of the brain does. And so the top of this picture is the outside of the cerebellum. And the bottom of this picture is as you go progressively downward toward the middle. And what this is a cross section. So if you had a birthday cake and cut a slice out, you know how you can see the different layers? There's the cake, and then there's the chocolate, and then there's another layer of cake, and then maybe there's some strawberry or whatever. This is meant to look like that. So these are the different layers of the cake, if you'd like. And there are three main ones. There's the molecular layer that's on the outside. There's the Purkinje layer, which is really important. We're going to spend a second on that one. And then there's the granular layer. So the punchline here is that information comes up. It goes in from the bottom of the slide, and it has to eventually get to the top where you see those parallel fibers coming from the granule cells down in the granular layer. And it has to be thought about and organized, and then eventually sent back down through the Purkinje cells. So the Purkinje cell, that sort of brown colored neuron that you see there with the, the sort of wavy seaweed looking tendrils in the molecular layer, that Purkinje cell is listening to all of the other inputs from these neurons going up and these connections there and making decisions about what to do. Then when it decides that, it sends information down. So that blue line going up, where you see mossy fiber, that's a highway going up, information coming in. And the Purkinje layer, that brown colored neuron you see, is sending information going down. That's going out, back out to the body. So this is consistent with what we know the cerebellum's supposed to do. It's supposed to get information going in, it's got to crunch it, and then it's got to make a decision and send information back out about whether you should be moving differently or doing things differently. So this is more of the same. We won't belabor this too badly, but I liked the image on the left because it's that sort of three-dimensional view that makes it a little easier to see. You can see that there's three layers again: the outer molecular layer, the Purkinje cell layer, and then the granule cell layer is the deepest one down. There's information coming in. I apologize for the small text, but those climbing fibers and the mossy fibers, that's information coming in. And again, you see the Purkinje cell over on the left-hand picture with many, many what we call arborizations, these sort of dendrites that are very spread out to go ahead and connect with all the other neurons around it. And so the beauty of this design by Mama Nature is that she has these things arranged in a grid. So if you look at the right side now, you can see that the Purkinje cells, their axons, if you'd like, are wrapped up in these parallel fibers that are coming from the granular cells in green behind them. So these connections, if they look like an orthogonal grid, like a 90-degree setup, that's because they largely are. And Mama Nature then has a ability to represent three-dimensional space according to where things are in the periphery in your cerebellum. So the cerebellum is what we call somatotopically organized. So there's a part of your cerebellum that corresponds to your right hand. There's another part that corresponds to your left hand. There's a part that corresponds to your right leg, and so on, because of this organization. And so why that's so interesting is because, and why it's so important is because it's very, 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 very integrated. So in a very short period of time, information about what your right foot is doing can be integrated with what your right hand is doing. Information about what your right hand is doing can be integrated with what your left hand is doing. And so if you're a guitarist, your right hand and your left hand, they need to know what each other is doing. And that's happening in real time in your cerebellum. Amazing. And so this is a really cool part of the brain. As the task implies, there's many, many, many neurons. As the slide implies, there's a million different types of neurons. Please don't get bogged down. I'm sorry for that. But you can see that there's a lot of different color neurons in there. They all have some different jobs to sort of create this message that has to go out. But the punchline, and then we'll leave this slide, and thank you for listening, is that the Purkinje cell on the right-hand side has to eventually tell the deep cerebellar nuclei what the story is. Here's what you're going to do. And that's really important because the deep cerebellar nuclei, that's the only real output from the cerebellum. So the punchline after all that number crunching is that the Purkinje cell tells the deep cerebellar nuclei what to do. And then those deep nuclei send information to the rest of the body. So why am I telling you all this? Well, it's interesting by itself, I hope, but in Huntington's disease, which we're talking about today, this has not really been thought about a ton. So think about that for a second. The part of the brain that has 80% of the neurons in it has not really been thought about at length in Huntington's disease. Well, why would that be? Well, when Huntington's was described as far as changes in brain structure, it was noticed that the striatum, which is the part that everyone thinks about, was clearly changing. And so that's your caudate nucleus and your putamen. You can see that on imaging. You can see that on neuropath. When you look at brain slices under a microscope, you can see that the neurons are changing. Over time, apart from the striatum, changes in the cortex also became more widely appreciated as we got more sophisticated in thinking about the connections, looking in other parts of the brain, following it through time and seeing change. That also has become very widely appreciated as changing. In fact, the white matter in the brain, which is situated below the cortex and what makes up the big bulk of the cortical hemispheres, that's also known to change with some fancier imaging techniques in the last couple of decades. So why is the cerebellum less appreciated? And why would this really important part of the brain not really get the same attention? Well, it's not as obvious, to be honest. It's not as obvious clinically. And I think it's been a little bit tricky to find neuropathologically, which we'll talk about in a second. So if we think about how we usually think of Huntington's, we know there's chorea, we know there's cognitive change and behavioral change. Those are the three big arms from a treatment standpoint that we go after. There are other movements than chorea. There's dystonia, where limbs can get stiff and sort of stuck as you're moving. There's Parkinsonism. So over time, the chorea tends to lessen and stiffness and slowness tend to pick up a bit. You're not overtly ataxic like in other cerebellar diseases. So if you look at diseases where it's only the cerebellum that's influenced, you can see that there's usually a way people look and move that's incoordinated or imbalanced. If you've ever had a glass or two too many of wine or champagne on New Year's Eve, you know what it feels like to have your cerebellum not quite serving you. And so that sort of jangly, unsteady, that incoordinated, unstable gait is often what is seen in other cerebellar diseases. And we know in Huntington's, chorea can be problematic, slowness called bradykinesia can be problematic, dystonia can be problematic. And so those things are reflected in our gold standard clinicometric measuring scale. And that's the Unified Huntington's Disease Rating Scale. If you look at the total motor score, you measure chorea, you measure slowness, you measure dystonia, but there's no overt way to say whether someone's ataxic. So even in looking at how we measure things, there's a legacy effect seen in how we measure things where we don't even really think about formal cerebellar function, which is really quite interesting. So why do we want to think about this? Well, if you look at people carefully enough, you can see that voluntary movement is impaired, and not necessarily from chorea or dystonia. So there's been this sort of anecdotal sense clinically that people can be ataxic, but it's just not gotten as much attention, in part because a lot of the involuntary stuff captures attention. But of course, voluntary movement is critical. And so whether there's anything that influences voluntary movement is really just as important. Although again, we tend to focus on the involuntary things and how that influences what we do. We know that gait and balance changes. We know that there's fall risk, and we know that speech changes. So all of those things are heavily related to cerebellar function. Think again back to if you've had a couple glasses of wine too many on New Year's Eve. You know your gait has changed. You know you might fall. You know your speech has changed. So again, illustrating this idea that these things can be more subtly present in Huntington's disease. And so we should probably think whether there's opportunities to explore treatment for cerebellar function if it's abnormal. And so let's go to the literature for a little bit. A couple things. What's in the scientific literature that tells us this is worthwhile? Well, there's a paper from Movement Disorders in 2014 where the authors looked at changes on MRI and wondered what that correlated to clinically. So they looked at 22 folks with Huntington's disease and 12 folks without, and they noticed that the cerebellar volume for people with Huntington's disease was impaired with gait and behavioral symptoms. They also used some fancy techniques to see how tightly packed the white matter was. And they noticed that there was less tightly packed white matter in people with Huntington's disease in a way that correlated with their total motor score. So in other words, as their total motor score was changing, the white matter was becoming a little bit less tightly packed because it was wearing down and degenerating. And they also noticed that eye movements, which are in part cerebellar, tandem gait, which is when you put one foot in front of the other, like you're walking on a tightrope, that's also cerebellar. That's a part of the cerebellum called the vermis that subtends that. And timed finger tapping, which is actually a speed and coordination task that the cerebellum has a lot to do with, also suffered in a way that correlated with these diffusion abnormalities. So you're getting indirect imaging evidence that the cerebellum and some of its outflow is impaired in Huntington's disease. You can also look at whether or not the nearby structures have changed. So the cerebellum is so complicated that it has friends nearby in a part of the brain called the brainstem. So if we look at this picture, we can see the cerebellum is on the right cerebellar hemisphere image. And some of the structures next to it, the peduncle, the pons, the medulla, there are nuclei that live in there, mesencephalon, quadrigeminal plate. There are places in there that have important connections with the cerebellum, and they also change. So in this brain pathology paper from 2014, they looked at that part of the brain to see whether there were changes, and there were. The pontine nuclei, a place called the inferior olivary nucleus, some of the medial, lateral, and superior vestibular nuclei. Those are the gyroscopes in your head. That's the part of your brain that tells you where you are in space when you turn your head. And so that information is really critical because your brain needs to know when you're moving, and if so, how fast and in what direction. And so if that isn't working because it's not communicating with the cerebellum properly, or they're not speaking the same language to one another, you can end up feeling unsteady. So we have evidence on pathology that the surrounding cerebellar structures, its sort of allies or friends, are also having trouble. So more recently, a group looked at whether cerebellar degeneration correlated with motor symptoms. And they were also interested in seeing whether or not that always held up compared to other types of symptoms people had in Huntington's disease. And they noticed that in separating people into two main groups, one that seemed to have more behavioral trouble and one that seemed to have more motor trouble, 43% loss of Purkinje cell layer was noticed in people with more motor dysfunction. So let's call a quick timeout and go back to that early slide where we remember that the Purkinje cell layer is the main output to these deep cerebellar nuclei. The Purkinje cell is the main decision maker, makes important judgments about what your movement should look like. And now they're going away as Huntington's advances. This is really important because it represents perhaps a part of the cerebellum that is especially vulnerable, one could wonder about. Interestingly, this loss didn't correlate to what your striatum looked like, because remember, that's the more famous part of the brain that changes in Huntington's, your CAG repeat length, or your age. So it's not immediately clear whether there's a dose effect, if you'd like, from these other things, like how long the CAG repeat is or how old you are. There's more to learn here. So this is a panel from that paper where they looked at people without Huntington's disease. The squiggly stuff you see, those are brain sections that are stained with things to allow you to see neurons and layers of the brain more easily. On the left side where it says control, that column going down, those are people without Huntington's disease. The middle column where it says HD mood, those are people who predominantly had mood trouble. And all the way to the right where it says HD motor, those are people who predominantly had movement trouble. And I want to draw your attention to the third row, those panels labeled G, H, and I. And so if you look at those sort of dark brown spots, those are cells. Those are neurons. Those are Purkinje cells, actually. And so you see there's a whole row of them in panel G. Then you go over to panel H, which is people with Huntington's and mood trouble. There's fewer of them. And then you move over one more, and you can see that in the motor section, there's even fewer. So this is an illustration of what they saw. People with motor dysfunction seem to have fewer of these Purkinje cells. And so when scientists look at the brain, they will stain the brain to show these things more easily. And they will actually sit there and count neurons, which I have done. It takes time, but it's really valuable because it allows you to see what it is that's actually happening. And so we'll look at one last paper here quickly. This is a clinical paper. So we talked about imaging, we talked about neuropathology. Well, what about clinic? In the end, that's what matters, right? What it is that people are showing you. What's the clinical translation? Because that's what you'd really want to be able to influence so that people felt better in developing a therapy. And so this group, which I really congratulate them for looking at this, and this is fairly recent, 2020, they looked at 72 patients who got examination with ataxia rating scales, or something called the International Cooperative Ataxia Rating Scale, the ICARS. And they noticed that at the time of the examination, all comers, so wherever you were in your disease trajectory, 71% of them formally met criteria on this ataxia rating scale. In fact, 8% of them had it as the first symptom and looking at what their historical trajectory was like, that surprised me, that it could be quite that high. And what's important here too is that in general, despite that 8% as the first symptom, it's typically associated with longer duration of disease and severity of illness. So here's a graphic depiction of that. There are 5 color lines on this slide. They correspond to different features of Huntington's. So you'll see at the very bottom, blue is chorea, orange is ataxia, purple is dystonia, yellow is behavioral, and green is cognitive. On the right side, the y-axis, you see that there's a percentage of participants who had these issues, and it goes from 50% to 100%. And you notice that on the x-axis going across the slide from right to left, you can see that there's time points by year, and they're grouped 0 to 5, 6 to 10, 11 to 15, and greater than 15. I want to draw your attention to the chorea curve, which is blue. You can see that through time, as people accumulate years with disease, the amount of chorea goes down. You see that blue line going down. If you look at the ataxia curve, you can see that it's relatively less common from 0 to 5 years compared to, say, chorea or dystonia, which is the purple line. But as you go 6 to 10 years, 11 to 15 years, you can see that the ataxia line is going up as the chorea line is going down and as the dystonia line is also going up. And as we know, behavioral and cognitive change also tends to advance with time. So this is, I think, surprising to many people who think about chorea because it's early, it's easy to see. Dystonia, a little harder to see, but also becomes more obvious. It's usually pointed out by a clinician. But look at ataxia, increasing steadily through time. So why I'm telling you this is probably an under-recognized problem that accumulates importance with time in the trajectory of Huntington's disease. So that just strengthens the idea that we need to start paying attention to this more. So last slide. Thank you for listening. What now? What would you say are the next steps? Well, an easy low-hanging fruit thing would be to wonder if medications that could influence cerebellar function are in fact helpful for ataxia and Huntington's disease. And so there's a number of medicines that are sometimes tried for ataxia, but I have to say there's not a lot. You know, if you see people with other cerebellar diseases and you look at the literature around them, they're relatively rare compared to, say, Parkinson's disease. And it's difficult to get anything to sort of make the cerebellum behave well because it is so complicated. And so the therapeutic index, if you'd like, the ability to elicit improvement and not make people feel bad, creating side effects, for a lot of these drugs in cerebellar diseases is pretty narrow. And so they're not easy to use because you might need to try high doses that people don't tolerate. They don't necessarily work. And so there's probably limited ceiling to trying this, but I put it here because there's not a whole lot of this at all in Huntington's disease. There have not been a lot of medications that could influence cerebellar function actually tried in well-designed clinical trials. So this is probably the first thing to think about. The next thing to think about, and in part, this is a little bit of hype because there's a fair amount of hype around this. The antisense oligonucleotides or the gene therapy studies, but particularly the ASO studies, you could wonder whether they would change cerebellar function. The reason why that's worth thinking about is because when people, for the moment, get their ASOs injected by lumbar puncture, they have to swim up towards the brain. And the cerebellum, remember, is situated in that kind of cool spot between the spinal cord and the brainstem and the big bulky part of the brain, the cerebrum. And there are spaces there where CSF, cerebrospinal fluid, bathes very closely to some of these very important structures in the cerebellum, you know, the fourth ventricle in particular. So you wonder whether there's an easy access point for the ASOs to get in there and maybe influence the cerebellum. That'll be very interesting. So I'm mentioning that really out of sort of scientific interest, since people are thinking about ASOs for, you know, the famous stuff. Does it change the striatum? Does it change the cortex? Well, I'm quite interested whether it does anything to the cerebellum too. So I wanted to be sure we were all thinking about that. The third thing would be alternative therapies. And this is something we're personally interested in at Cooper. You know, Amy, myself, Dr. Basant Pradhan, who's a psychiatrist with a background in neurology, we're thinking over whether stimulating the cerebellum would be a good idea. And so the Purkinje cells, remember, they're the main output. We talked about that. And they have a very modifying influence on the deep nuclei in the cerebellum. They sort of cool it off from its normal excitatory role for the rest of the cortex. And so there's this loop. And so we're wondering whether if the Purkinje cells are going away, maybe that's not a target, but if the deep cerebellar nuclei are there, maybe we stimulate them. Maybe we sort of mimic what Purkinje cells normally do with a magnetic field. That's the idea. So we're in the process of drawing that up. And in the sense that that's a clinical trial, you might be interested, and we'd be interested in talking to you more. That sounds like it might be cool. We'll let you know more as we sort of get this crystallized. We may be advertising if people are interested in volunteering and being in the study. So please stay tuned. This would not be a medication. It would not be pharmacologic. in the sense that medicines are chemicals that bind to receptors and elicit changes in cells. This would be a magnetic field that could be turned on or off. And so what we'd have to learn is whether or not any effect persisted. And we'd have to also learn, if it worked, how often do you need it? So to be determined. Keep your eyes peeled and your ears tuned. And so finally, that really just underscores we don't have much for this. We need novel approaches to cerebellar function. And I think with time, and more sophisticated pharmacological approaches, and hopefully something even with magnetic stimulation, I think we're going to be a little bit better able to modify this clinically, and hopefully then a lot better able eventually. So I'll stop there. I know that's a lot on a Saturday morning. Hope to not bore you with the science, but I think a lot of people like it, and I think this is really exciting. So thank you for your time. Happy to take any questions.
Thank you, Dr. McGarry. I actually do have one question that came through the chat for you, and maybe potentially for everybody. Has there been any slowing down of HD research due to COVID? Has it affected any studies?
That's a good question. I think as a general matter, COVID clearly influenced what people are able to do early on in particular. A lot of what we do is clinically driven. So outcome measures that have to be obtained in person, imaging studies that have to be obtained surrounded by other people, who operate the imaging devices or who also contemporaneously, administer other scales, clinical outcomes. So I'd say as a general matter, everything suffered, especially early on. I do think what we've noticed is that sites and particularly participants are very resilient and quite adaptive. And in a really short period of time, protocols for clinical studies were modified quite impressively to allow for outcome measures to be done remotely. And so that could either be through a video screen or a telephone. And in other instances, trying to minimize exposure to other people. So I have to think, I don't think any major Huntington studies managed to escape this effect early, but I'm fairly confident that, like most other studies, they figured out how to keep going.
Okay. I think, Stacy, did you have something to add to that? I know.
Yeah, thank you, actually, Dr. McGarry. That was a great presentation. I keep calling you Dr. McGarry. You're always going to be Dr. McGarry to me. That was such a good presentation. I'm a science nerd.
Yeah, well, Dr. Stacy, you're a scientist.
But the loss of the Purkinje cells, that 43% loss in people with HD patients, I think is fascinating, because one of the things we're always trying to figure out is the differences, and the fact that it didn't correlate to the CAG levels or the age of onset in people, to me, is fascinating. I mean, could that be something that is partial? I know you don't like to say for sure, but could that be one of the contributing factors to the differences in age of onset with people with the disease? Because there's a huge variation. When you look at all those studies with the age of onset, there's a huge variation. And I know it's linked to a lot of different things, but do you think this could possibly be one of those factors too, that they haven't really explored?
It's a good question. In that small set in the study, they didn't notice that there was a relationship between age of onset or Purkinje cell loss. And that's a really good question, because to some degree, you're wondering, okay, with time, we expect neurons to be lost. And so if you've had it longer, meaning generally it showed up earlier, so therefore you've had it longer, does that mean you've had more time to lose these? Does that say something about a gradual process? Or do they get lost selectively in some other way? In other words, could you have Huntington's for a year and a half and really lose a lot of Purkinje neurons because they're selectively vulnerable? I don't think anybody knows that. That's a really interesting idea. Is there something in some people that would make the cerebellum especially vulnerable and maybe have more of a motor phenotype early versus later on? Because we do know that some people have very little chorea, and I don't mean adjusted for duration of disease, where we know that generally speaking, it lessens. There are people that for one reason or another just don't have a lot of it. And then there are people who have a ton of it. And we don't even really still know why that is. On a molecular basis, what is it that's changing in some people more than others? So very similarly, you could wonder, is there anything to separate people who are more ataxic than not? And how would you predict that? And that's part of your question, which is a really good one. Is it age? Is it CAG? Is there something else that would help you predict? And we don't really have a good way of doing that, in part because there's not a ton of research just yet. You can see it kind of trickling out in our presentation today. A couple papers from 2014, one from 2020, 2019. So, a really ripe area to explore, I think, would be what it is that goes on in animal models in the cerebellum, because rats and mice, they have Purkinje cells. And you could look and see what it is that's changing, how to modify them. You could imagine a lot of good basic science that could be done to try to improve Purkinje cell function. So great question. And like many things, we don't know.
I know, unfortunately, I know, because I know with Korea, my mom didn't have it and I don't have any. So it's a good thing. Well, you also talked about some of the medications that may influence the cerebellum. Are they already being used? Like Cloenza, I can't say this. Why can't I say this? Clonazepam. Thank you. Like those types of medications, are they approved already for other uses?
They are. Clonazepam is kind of a Swiss Army knife medication. It can be used in Huntington's for anxiety or trouble sleeping. So there are very likely some people who do take it. It's not been studied, to my knowledge, for things other than that. So in other words, it's not been studied with the express purpose of seeing if people have changes in their coordination or their gait. It's not been looked at as a treatment for ataxia. But
they approved medications.
So clonazepam is an FDA-approved medication. It's been around for a long time, right? And bupropion is also an antidepressant. That's been around for a while too. And that could be used in any generic sense to treat depression and Huntington's like anyone else. But it's not, to my knowledge, been studied expressly for ataxia in Huntington's.
Okay. Very cool. It's so interesting. There's so many good things going on. The magnetic stimulation study too. I think if you guys do that, I'm sure we can find plenty of volunteers.
That's great. We're still in the lab, if you'd like, figuring out how to best design that study, which I think is a lot of fun and really exciting, because the odds that it would be problematic the way medication sometimes can be, I think, would be low. And I also think that the temporary nature of the stimulation would also limit the potential side effects that someone would have. Of course, that's potentially a downside. If it's helpful, if the effect goes away, the next thing to figure out is, well, how do you get that to be sustained? And that's the next problem to have is, and a nice problem to have would be, well, is this something people would do every day? Would they put it on, for a couple hours a day to supplement, whatever medications they might be taking? Would it be used intermittently, maybe twice a day, once in the morning or once in the evening? We have no idea, because we don't even know what it does yet. So first things first, we want to establish whether in the clinic there's a visible effect, and then thereafter, the best use, if you'd like, the proper dosage, if you'd like, would have to be figured out in a much larger study. So this is still on the drawing board. We sort of showed you the drawing board.
It was a very drawing board. Thank you.
Sure.
One more question, Dr. McGarry, and I don't know if you know I think I know the answer. Somebody asked if brain donation is still happening. I know that Kayla and I have been working on updating, mostly Kayla, updating our resource guide, and we did call recently, and they did not say anything about not accepting brain donations, but I don't know if you've heard anything.
I confess I don't know. I don't know if Amy might, but I'm not aware. We could see locally, when I think of Neuropath, I think of Virginia Lee and John Trojanowski at Penn. I don't know how many Huntington's donations they take. We do a lot of Parkinson's and Alzheimer's, but
I know we do usually give out the information for Harvard, and then I believe Massachusetts General.
Yeah, Harvard Brain Bank is the big one, right? And I don't know, although I can ask them.
Okay, all right. And then Dr. Colcher, there was a question for you. Do you see any
Nope, sorry, Corlin, I think your feed might have
I
paused.
think it did. Yeah, sorry about that. So there was a question about for Dr. Colcher if she saw any reason to not get the vaccine. And I think I know the answer to that, but I don't want to speak for anybody. I don't know if she's still there. All right, well.
Her feed might be a little bit off, but it can be a little wonky, but I'd say as a general matter, no, there's no reason to not get it. And it's sort of an individual decision based on your comfort with the science. I've had people say, hey, this sounds neat, but they got it done inside a year. Does that make it fishy? Did they cut corners? And I just want to remind people when they ask that good question, the outcome measure for those studies was what happened in your blood, which was very easy to measure. And a very important outcome that also happened, other than, hey, did you make antibodies, was while you were in the study, did you get sick? And it's remarkable, when people did get sick, which was clearly more rare in the treatment group, meaning the people who were given active vaccination. The most important part, I think, is that no one got really sick. That's the key. When you think about how deadly the virus can be and how hard it is to know in whom that necessarily will be, although the risk factors that Amy mentioned are certainly important, it's really something you don't want to get at all if you can help it. And to see that people really didn't get very ill when they were treated, I thought was very encouraging. I also think the technology is pretty remarkable. It's everything you need to make antibodies and nothing more. It's just a blueprint. You go ahead and read the blueprint, you manufacture the protein, it's seen as immunogenic, you make ammunition against it, you're good to go. It's really quite remarkable. So, I can't think of a reason, considering all of the heavy duty things Amy mentioned about what being sick is like, that you should not go ahead and protect yourself against those things. In other words, I think people should get it.
Okay. All right. Thank you. All right. Well, thank you, Dr. McGarry. Really appreciate your time today. We're going to be now moving on to Kayla Cupano, who is who's an occupational therapy student. Again, she's been working on her capstone project with me over at Cooper, and she's just been a tremendous asset and a huge help. So I don't know, Dr. McGarry, are you able to stop sharing your screen? And then, oh, perfect. All right. So I'm going to, there we go. I'm going to put that pin on Kayla. And if you want to go ahead and introduce yourself and start your talk, that would be great.
All right, 1 moment. Okay. So hi, my name is Kayla, and I'm a student from Southeastern University, and I'm completing my capstone project with Coraline and helping out with Cooper Neurology as best as I can. And I wanted to thank you all for your time today. And I will be presenting on the daily living strategies for individuals with HD from an occupational therapy perspective. Oops. So I first wanted to mention the 2 different resources that I have been working on during my time. As Coraline had mentioned, I'm working with her on the resource guide for the New Jersey chapter and updating that. It would be definitely beneficial for all of you. And the different types of things that we have included so far are different social service agencies within the county. There's information on support groups and counseling, driving evaluations, long-term care, information about the brain donation, and help with medications and finances. So this will be posted on the website soon. We are in the process of finishing it up. And the other resource that I've created is a booklet that has all of these topics on different equipment, activities of daily living tips, fall prevention strategies, cognitive, postural, motor-based, and mobility strategies, different types of therapy, and some mental health tips. This resource is available in a physical copy in the Cooper Neurology office, but also virtually. So if you are interested in it, you can always reach out to Coraline and she can send you certain parts of it or the whole thing if you'd like. So what is occupational therapy? Occupational therapy is an evidence-based healthcare profession and part of the rehabilitation team that assists individuals across the lifespan and aims to solve problems and barriers that interfere with a person's ability to engage in activities meaningful to them, known as occupations. OTs provide the most effective treatment that is up to date with current research, and it is client-centered. An occupation is an activity that holds meaning and provides purpose within your daily life. So these can be things that you want to do, need to do, or you're expected to do based on your role in the family or within the community. Some examples of occupations include driving, handwriting and typing, cooking and meal preparation, taking care of a pet, dressing, gardening, grooming tasks, and all of the leisure and social participation activities. There are 8 areas of occupations that OTs address when working with a client. We work on the activities of daily living, ADLs, instrumental activities of daily living, IADLs, rest and sleep, education, work, leisure, play, and social participation. So to break down what are ADLs, they are bathing, dental hygiene, toileting and toilet hygiene, eating and feeding, dressing, and transfers and mobility within the community or in the home. And IADLs involve cooking and meal preparation, house cleaning, taking medication and managing the medication, laundry, shopping, personal finances, communication, and transportation. So these are all areas that OTs can help with. So generally, there are 3 types of therapies that you will come across within the span of HD. And these include physical therapy, occupational therapy, and speech therapy. Each therapy has its own scope of practice. We all have our own expertise and we work on different goals, but we all work together and we collaborate to meet the best needs of that client. So for physical therapy, they use a biomechanical approach to improve ability to perform movement. They utilize therapeutic exercise, mobility, and manual therapy to help a person get from point A to point B. Occupational therapy utilizes a holistic whole person approach to improve the ability to perform ADLs to maximize function and independence in the environment, routine, roles in an activity. And we use the supports and identify and navigate the barriers to help a person do things at point A and point B. And speech therapy improves the ability to communicate and works on cognitive and thinking skills, chewing and swallowing, language skills, and memory. And they will also sometimes use augmentative and alternative communication devices. So to receive OT services, and generally any type of therapy services, a physician's script or a referral is typically required. It is a covered skilled therapy service under Medicare. And so for OT, we work to create and promote occupational performance, modify the task and environment through compensatory and adaptation strategies, provide assistive equipment and make recommendations when appropriate, establish and restore a skill or ability that has been impaired, and provide patient and caregiver education. We may work on things like therapeutic exercise, ADL training, balance and fall prevention, home modification and home safety evaluations, cognition, motor planning, and mental health. And generally for all of these therapies, we like to see people right at the beginning of a diagnosis, or to prevent a lot of the issues that may occur and just slow those down in the best way that we can, rather than seeing them after a fall or after you're having a major issue. These are the different types of areas that an OT would work with someone with HD. So for cognition, we work on the activity and the demands of that activity and being able to shift and maintain attention, as well as short-term memory, understanding medication schedule and organizing the medication, initiation and termination of tasks, learning a new task, mental health, and establishing a daily routine. For chorea, we work on the coordination of fine motor tasks that may be affected by the chorea, such as grooming, feeding, leisure activities, and medication management, and being able to open bottles or open containers. And understanding what areas of your life might be impacted by this and the decreased coordination, such as in your self-care or if you're working, and any function and safety within the home. We also work on balance. We will make recommendations on adaptive equipment for hygiene, such as bathing and meal preparation. We work on exercise and balance training and advocate for equipment and assistance when utilizing mobility devices. And that's where it comes into play with physical therapy, is that we collaborate. They will determine what device is best appropriate, and then we will help you to utilize that device within the community. We also work on engagement and meaningful activities, such as establishing activities that are important to the routine or the role of the person. If it's important for you to be able to take care of your dog, or to go get the mail every day, or to clean the house, we'll work on adapting those activities to meet your needs. And we will always work on modifying the activity, not necessarily modifying and changing the individual. We also work on visual perceptual skills, which is utilized for functional mobility and navigating your environment, as well as during driving and initiating the dialogue of how to prepare for retiring from driving if that is becoming an issue. Home safety assessments are done by OTs. We will complete a home walkthrough using a checklist and identify any hazards within the home and recommend any modifications or adaptive equipment. And we will look at all areas. So with the floor, is there clutter or wires, any throw rugs or uneven surfaces? We will look at the lighting in the stairway, hallway, throughout the home, inside and outside, and if it's easy to find the light switches. Outside, we will look at the walkways, even pathways, any slippery surfaces, and if there's any tools or anything blocking you from your direct path into your home. And at the furniture, to make sure that it's steady and that all of the items that you need are within reach, as well as having handrails on the stairs or maybe the bed and maybe some grab bars in the bathroom. If a person is homebound and spends most of their time in the home, and an OT can see the benefit of further interventions within the home, then they will recommend in-home skilled therapy services. The visual environment is also very important. Having a direct route to get from one place to another is important. So not having that coffee table right in the middle of the room, but maybe to the side. And also having cue cards if there's a certain task that is difficult to complete, or a visual schedule. So it can be done in several ways. You can have, 4 words to fasten a button. Grip the button, find the hole, push button into hole, and pull. If getting up from a chair is an issue, then you can have more detailed written instructions, or turning in bed, as you can see in the middle. And then you can also have a visual schedule. So for brushing teeth, for example, where you have a picture and then you have the steps. That also helps with the cognition piece. These are some strategies for cognition: creating a daily routine as best as possible, providing cues, doing a gesture, a verbal cue, a physical cue, or tactile, which is touch, labeling frequently used drawers and cabinets, short, concise, when giving directions, to reduce distracting stimuli as much as possible, to create lists and calendars or notes to keep track of any tasks, and to break those complex tasks into more simpler components, utilizing the visual schedule or cue cards, and to always encourage completion of one step before moving to the next. Some postural control strategies. We really focus on the person being self-aware of posture and being able to just give a verbal cue of sitting up straight, or just saying the word posture to go from leaning to a more upright position. High-backed chairs with armrests are very helpful. They provide support, and also the armrest will help you to get in and out of the chair. If you are watching TV or watching anything, we recommend having it directly in front of you rather than to the side to prevent that lateral lean. And using a chair raiser or an electric chair that rises for easier transfers getting up and down. Exercise and balance is very important, as we know with OT and HD. And with HD, exercise that might be worked on is flexibility, balance, cardio, core strength, lateral, which is side-to-side movements, and squats. An active range of motion exercises are used to prevent muscle or joint contractures and can be completed lying down or seated in a supportive chair to maintain balance. If you have any pain with exercise, you should always stop, and also to limit the use of weights and to use your own body when exercising. So that goes into functional strength training to maintain your strength. Simply standing up and down from a chair is using your own body to maintain that strength rather than using weights or anything resistive. Lifting an object onto a shelf, or using something that is a push-pull method. And OTs may also work on positioning of feet and different balance positions, various head and arm positions when you're doing that, as well as standing on different surfaces. We always incorporate a functional activity into balance training. And all balance activities should be discussed, obviously, with a physician and a therapist based on their care and recommendations. So I'm going to go into just different areas of your life and some strategies that may be helpful. An OT is definitely a valuable team member in addressing function in the workplace. That is an occupation. We can work with communication with the employer, providing accommodations and modifications for the task, and also advocating for your rights and making sure that you know your rights through the Americans with Disability Act. Some strategies in the workplace, although it can be difficult depending where you are to reduce distracting stimuli as much as possible, maybe modify some of the responsibilities or the task and utilize adaptive equipment if that seems appropriate. Consider changing employment to something more accommodating, or possibly consider different volunteer positions to keep you engaged in the community, and to reduce the responsibilities that might be too fast-paced, detail-oriented, or with variable conditions. For driving, OTs can receive a special driver rehabilitation certification to administer comprehensive driving evaluations. This is done in the office and also a behind the wheel assessment to assess the physical, mental, and visual abilities for safe driving. We look at reaction time, visual acuity, decision-making, judgment, and planning, which you need all of those for driving. The physician will do a medical assessment and determine if an OT is needed for a behind the wheel and further assessment. So we provide the functional assessment. We will also assist and initiate the dialogue for planning retirement from driving if we don't see driving as appropriate at that time. Based on the performance, we will work with the individual to create a plan, recommend strategies, equipment, and training, and increase awareness of resources for alternative forms of transportation. For social participation, it's very important, especially during this time and in the pandemic when social participation and communicating with others is limited, to create a daily routine for yourself and to maybe schedule times to talk to other people, whether that's through video chat or talking on the phone, taking time to write a letter or email to someone. It's also good to have different visual and verbal reminders for yourself to do that. and to participate in different events and different support groups. Leisure activities, maybe thinking back to hobbies that were of interest to you and things that you used to do that maybe you would be interested in doing now, or things that you're already working on now and things that you might be interested in the future, taking the time, especially now, to do that. We know that exercise is important, and exercises such as Tai Chi and yoga are also very beneficial. This is a quote from an article that I really liked. It says, "Ensure that the activity is adapted to fit the person and not the other way around." And this is a true essence of what OT stands for, is we adapt the activity and the environment. And we want to adapt your surroundings to fit your needs, not fitting and changing you to fit the world. For home management, for doing laundry, let's say, some strategies are to use a timer for when it's complete. You can use a laundry basket with wheels or a handle or a shoulder strap. And you can be in supportive seating and use a reacher to reach in and out of the washer and dryer. For meal preparation, doing one task at a time, because meal preparation is exhausting and also requires a lot of attention. And having supervision when you are doing meals on the stove and the oven, as well as maybe moving to more simpler meals that require 1 to 2 steps, utilizing a lot of the adaptive equipment, which I'll talk about in a moment, and having all your frequently used items within reach. So I know last year when I did a presentation, I focused a lot on the equipment. So I have it all here and I'm going to go through it. But if you have any questions specifically, feel free to ask. So for dressing, there's using Velcro or elastic waistbands, a long-handled shoe horn for taking on and off your shoe, a dressing stick, which can be used to get behind you or to reach down, elastic shoelaces, and a sock aid, which I actually will have a picture on it on the next slide. And then for toileting, there is a 3-in-1 commode where you can have it at bedside as is like that. You can also remove the bucket and just put it over a toilet. So now you have a raised toilet seat. Or if you have a toilet already that you wanted to put bars on or raise, you can do that as well. The Freedom Wand can be used for toilet hygiene and for different bathing and grooming activities. For dressing, some strategies are to sit down when you're able to decrease your fall risk and for supported posture and balance when you're reaching and bending, and to pair and label outfits together ahead of time. There are several adaptive clothing lines out there. This one has magnets behind the buttons so that when you're putting on a dress shirt, it's easy to open and close. It's something that you can probably do on your own as well, and I'll just show you what that looks like. So just a simple thing that you can do. And also this is how to use a sock aid.
Sit at the edge of the bed or in a supportive chair with armrests. Place the sock aid between your legs. Bunch the sock up as if you would a stocking. Then slide it onto the tip of the sock aid. Pull the sock up over the sock aid, stopping just before the knots on either side. Drop the sock aid to the floor while holding on to the rope handles. Slide your foot into the sock aid and pull the handled ropes back and up so that the sock slides up over your heel. You can shorten the ropes by wrapping them around your hands once or twice if necessary.
Okay. For bathing, there are shower chairs that have detachable armrests you can put in a shower stall. A tub transfer bench has the 2 legs outside of the tub, so you can sit and then swing over your legs. Grab bars, it's very important to have grab bars properly installed and not using suction cups, ones that may fall and then cause an increased fall risk. And a long-handled sponge. For grooming, there's also using an electric toothbrush or a toothbrush or razor with a built-up handle. There's also different devices out there called Easy Holds, which you can use on several different items for a little bit of an easier grasp on some of those smaller items. Medication management. We work on organizing your medication and being able to use the different management devices. So using a pill box, they have ones that have spring-loaded assistance, so it's a little bit easier. There's also vibration timers where you can actually store the medication in the timer and then it will vibrate and make a sound when it's time to take it. There are several pill reminder applications on smartphones, as well as the Hero pill dispenser. It is definitely more costly, but it does automatically dispense your medication. You have it set up through your phone. It will dispense it at the proper times. The oral flow is good for swallowing. The medication goes into the spout, so it never actually sits on your tongue. You fill the cup up with water and then just drink it as if you're drinking water, and the pill will go down easier. And also using a high contrast tray, like a black plate or a red plate, when you have lots of medications that might be all white and it might be hard to differentiate. For eating and feeding, using weighted utensils, they make ones that have a wider grip, like the first picture there on the left, and then next to it, those are also weighted, but they look more like standard utensils. A universal cuff goes across your palm, and you can put a fork or knife or spoon into it. A rocking tea knife has a wider grip and allows you to do a rocking motion to cut food. A plate guard goes on the edge of the plate to prevent food from falling off. And Dysum is the blue mat. It prevents things from sliding off of the surface. So it's kind of like a placemat. They also make bowls with like a high side if food spillage is an issue. And speaking with the speech and language pathologist to see what the best thing to do for drinking is, but they do have nosy cups that have a higher side for when you're drinking or using a bendable straw. For eating and meal times, weighted utensils provide that additional weight to stabilize hand and support in weakened grasps. They also are about a half a pound each. Individuals with HD may require a high calorie diet, so that's important to keep in mind. We encourage people to eat at the table to reduce spills, promote social interaction and conversation with others, and to reduce distractions, and to prepare meals and snacks in advance so that you can retrieve them easily throughout the day and not having to take the time to create a meal each time. And we also promote as much independence during meal times as possible. For transferring, there are things like a transfer board, a bed rail, a power lift chair, and there's also a bed cane. For mobility, we encourage to plan scheduled rest breaks throughout the day and to plan out the day and prioritize your activities during the days and during the times of day when you have most energy. A recumbent bike is a good adaptive bike that's good for exercise. There are also trekking poles, which is good for walking. There are several types of canes and walkers and wheelchairs. So they all have different handles. We have the C cane, functional grip, offset, the quad cane with the 4 prongs, and they also have folding walking canes. And for walkers, we have a standard, a 2-wheeled, and a rollator that has 4 wheels, and then the basket. And typically these are covered by Medicare every 5 years. For wheelchairs, there are manual wheelchairs, transport wheelchairs, which are lightweight, easy to fold up, high back reclining wheelchairs, and power chairs. This is just a short video of how to get in and out of bed doing a log roll.
This is a demonstration of a patient rolling from supine to sideline and then sideline to sitting. Have the patient bend the right knee and push down on the right knee at the same time reaching across the body with the right hand to achieve a sideline position. Once the patient's in sideline, have them bend the left elbow and push down with the left elbow and with the right hand and bend the knees so the feet go over the edge of the table. At the same time, the feet go down, push down with the hands.
And then this is one for getting from a chair to another surface.
Today we're going to show you the proper way to transfer a patient from a wheelchair to a medical table. This type of transfer is called a stand pivot transfer. This is used when a patient can stand but may be a little weak or need extra help. For your safety and the safety of the patient, always use a gait belt. The belt should be placed low around the patient's stomach at about the height of the belly button. Be careful to watch or ask the patient about any recent abdominal surgeries or colostomy bags. In those cases, you may have to place the belt higher or lower to avoid incisions or devices. If you are transferring from a wheelchair, make sure the brakes are locked and the leg rests have been swung out of the way or removed to avoid any possible skin tears or tripping. Make sure the chair is at about a 45-degree angle to whatever surface you are transferring to. Have the patient scoot their bottom towards the edge of the seat. Explain to the patient exactly what you plan to do and what you need from them. Stand in front of the patient with a hand on either side of the belt. Squat to use your legs to lift, not your back. On the count of 3, help lift the patient to a standing position. Have the patient shuffle their feet until the back of the patient's legs are touching the table. Tell the patient to reach back for the table and have a seat. Make sure the patient is safely on the table and then remove the gait belt.
Okay. And for the last of the adaptive equipment, for daily living tools, there are things such as a key turner, a reacher, a jar opener, page turner for reading books, and a universal turning handle, which can be used on a stove or a microwave. And an enlarged and brightened keyboard. There are different typing aids and also several accessibility features on smartphones. For mental health, COVID-19 has had a mental health impact on everyone. Media outlets display the continuous coverage. You might be worried about securing food and household items and medications. You may be unsure about the safety of caregivers, transportation, procedures, and appointments. There is a decreased social interaction with others. There is definitely a halt of daily routine, habits, and roles, and an exacerbation of mental health conditions may result of this. There is an act that was re-amended in 2020 called the Older Americans Act. It's just good to know about. They are working on funding, resources, support for caregivers, including education and respite care, pension counseling, nutritional services, disease prevention, and community workforce training. NOTs are important in mental health because we provide interventions, support, and programs related to community-based settings, health promotion, and disease prevention. We promote participation and encouragement in meaningful activities and recommend adaptations and modifications to the environment to support safe aging in place and reduce social isolation. And finally, some mental health strategies during this time are to create a routine as best as possible, having something to look forward to that day or the next day, having a balance of exercise and relaxation, using alternative forms of communication with others. If you are a caregiver, sometimes having your name or a picture of your face next to you or on a tag on your shirt or something would be helpful for people that might not know who you are due to a mask and other covering. Validate feelings and encourage self-advocacy and self-expression. Have accessible, safe areas to walk around in the home or in the outside environment to increase movement and exercise throughout the day. Allow time to complete an activity. Try to plan the day and stay active and to maintain that connection with others. And ensure that all adaptive devices and equipment are available and within reach. Some activities that you can do are to reminisce, to stay positive as best you can, and do some breathing exercises. Listen to music, do enjoyed activities, expand your creativity, engage in purposeful activities, maybe have a checklist for the day and then plan for the next day. Of course, use laughing and humor, connecting with others, writing letters, or maybe sending artwork or writing cards, and engaging in the virtual experiences such as email, video chat, religious services, and support groups, and always to engage your 5 senses throughout the day as best as you can. Here are my references. And that's it. Thank you so much.
Thank you, Kayla. I really appreciate you taking the time to go over all that. There's some really interesting stuff in there. There is somebody who did have a question, and I don't know how much we have an answer for it. She has a brother in a nursing home and had wondered, what are some things to keep him engaged. I know one of the barriers right now is that I've been hearing that OT, PT, and speech are happening less in long-term care facilities, including rehabs, than they used to. So I don't know, with that in mind, if you have any other thoughts on that.
Yes, I've also heard that as well. And I think that goes back to a lot of the mental health strategies, because when you're not as engaged, then that affects your mental health. But I think sometimes I've heard people doing like making scrapbooks or making like photo albums of loved ones, or with different activities that they enjoy doing, using magazines or things off the internet. And really just going back to some activities and creativity that maybe were of interest at one point, whether that's trivia or bingo or an exercise class. They have several things depending on the resources, videos that you can watch just to get you moving and get your brain thinking, different types of puzzles, and really just trying to stay as active and maybe plan some of those important activities and different things. I know that therapy is definitely taking a toll in those settings right now, and it's difficult to visit anyone, but just trying to be creative in what you do have there.
All right, great, thank you. Any other questions for Kayla? All right. Well, I really wanted to just say thank you to everybody for everybody's effort and for being here today. Certainly, if anybody ever needs anything in terms of HD, any family members, any resources, feel free to reach out to the HDSA New Jersey chapter or to call me directly. I'm always happy to talk. So I just really appreciate everybody's time today. I would really love to thank our 3 speakers for their time. And if anybody has anything else, no questions. Okay. Well, thank you everyone for your time today. I hope you enjoy the rest of the Saturday. It is sunny, so we'll take that. All right. Have a great day.
Coraline, it was
Yes.
it was a great job. Thank you.
Oh, thank you.
Speakers, thank you to everyone. It was a really great morning. Thank you.
Yeah, and hopefully we'll get to see you all in person next year. So fingers crossed.
We hope, right?
Yep. Hope. All right, excellent. Take care, everybody.
You too.
Thank
Thank you, Carla.
I know I had COVID, so I'm happy to hear that tiredness is normal.
Oh yeah, I think there's some of that stuff that just lasts for quite a long time.
Tiredness, I can't
Yeah.
get rid of. And when she said that, I was like, oh, good, thank you. I was like,
You might be a little while.
all right.
You know
Well,
what? Being tired during the winter is not so bad. Maybe when it's nice out, you'll get your energy back. And
I know. Thank you.
yeah, well, take care, everybody.
Thanks. Bye, hon.
Bye-bye.